Yes, can we start?
Yes, ma'am.
Oh. Yes, hello everyone. So welcome back. So we are just starting after the break. So the remaining of cardiovascular system. So we just finished the pressure volume loop of the left ventricle. Go to JVP, jugular venous pulse or jugular venous pressure. What is JVP? First, let's understand what are we recording by JVP. This is the right atrium, the internal jugular veins. They directly drain into the right atrium of the heart. Internal jugular veins. So whenever you want to record the right atrial pressure, you can measure internal jugular vein pressure. It will indirectly tell you how much is the right atrial pressure. So what is JVP? JVP is a measure of right atrial pressure. That is why whenever we correlate the waves of JVP, we correlate this to the right atrial events or just the atrial events. JVP waves will correlate only to the atrial events. Don't confuse with the ventricle because JVP is a measure of right atrial pressure only with the atrium. For example, A wave in a JVP, A for atrial contraction. A for atrial contraction. When atrium is contracting, you will see the A wave. Yeah, I think somebody has to mute. Yes, I think somebody has to mute. Okay. A wave in JVP, A for atrial contraction. When atrium is contracting, A wave. C wave for tricuspid bulge. During isovolumetric contraction phase, when all the valves are closed and the pressure is rising, the tricuspid valve will bulge. So that will result in C for tricuspid bulge. X for atrial relaxation. When atrium is relaxing, X wave. V for venous filling of the atrium, when veins are filling into the atrium. And Y for atrial emptying, when atrium is emptying, this is Y wave. So we have correlated the JVP waves only with atrial events. Don't confuse with any of the ventricular events, only with the atrial events. Over to cardiac muscle action potential, very important. We have already discussed nerve action potential. So you know this, depolarization due to sodium influx, repolarization is due to potassium efflux. This you already know. So now we will see what is the difference between this nerve action potential and cardiac action potential in the heart. The heart fibers, there are two different type of fibers. Normal cardiac ventricle action potential and SA node action potential. First, we will do cardiac ventricle action potential. This is same as the nerve. Only difference is that during depolarization, it is same sodium influx. This is called phase 0. And repolarization starts in phase 1 itself and it is complete in phase 3. This is repolarization due to potassium efflux. That is also same as the nerve. But what is the difference? In between depolarization and repolarization, we have the plateau phase, a flat phase with no electrical activity. This is a plateau phase. Why there is no electrical activity? Because of opening of L type of calcium channels, long lasting type of calcium channels. I'll tell you what happens during repolarization. Potassium moves out, that you know. In phase 1 itself, potassium begins to move out. But there is opening of this calcium channel and suddenly calcium comes inside. Potassium is a positive ion going out. Calcium is also a positive ion coming inside. One positivity going out, one positivity is coming inside. Both will balance each other. When both balance each other, there is no net electrical activity. That is why it is a plateau phase. It is a flat line. What is the clinical importance of this? If you want to control the heart rate, you can give a drug which will block this plateau phase. Tell me the name of the drug. The drug which will block this plateau phase. Yes, if I give a drug, it is going to block this phase. It is going to control your heart rate. It is going to be used as an antiarrhythmic drug. Excellent, Ranjan. CCB, cardio. Yes, calcium channel blockers. Nifedipine, verapamil, amlodipine, diltiazem, all of them are calcium channel blockers. That is how calcium channel blockers are used as antiarrhythmic drugs because they block one phase of cardiac action potential. Over to SA node action potential. What is so special here? Depolarizations are due to calcium influx. I already told you this. One exception where depolarization is due to calcium influx is the SA node, not due to sodium but due to calcium because of L type of calcium channels. The other difference is that this slopey phase, this phase 4 is called as pacemaker potential. Pacemaker potential or slow diastolic depolarization phase. This phase only is responsible for the pacemaker activity. There are three channels which contribute to the pacemaker activity. IF, it's a funny channel. TCAL, transient type of calcium channel. And NCX, sodium calcium exchanger. These three channels are responsible for the pacemaker activity. So that's the specialty of cardiac muscle action potential. Over to factors affecting cardiac output. Cardiac output is equal to heart rate into stroke volume. Heart rate into stroke volume. Heart rate. What are the factors which determine heart rate? Yes. So this is determined by parasympathetic and sympathetic. Very good. Parasympathetic. Yes, we have Anirudh. Good. Parasympathetic and sympathetic. Parasympathetic will decrease the heart rate, sympathetic will increase the heart rate. So parasympathetic and sympathetic will affect the cardiac output. Other factors, stroke volume. What is a stroke? Stroke means heart is beating, it is striking. So contracting. Contractility itself is a factor which affects cardiac output because more the contractility, more will be the stroke volume. So this is directly proportional to stroke volume, contractility. There are two other factors, preload and afterload. What is preload? So look at me. Please look at me. All of you listen. This is a balloon. I'm going to load this balloon. You just see how I'm going to load it. Before loading, see what I'm doing. I'm going to fill air into this. Only if you fill air, it will be loaded. So before loading, what did I do? I have filled in. So what is happening before load? Preload, filling. Yes, preload means filling of the heart. Preload means filling. Who will fill the heart? Veins only will fill the heart. That is called venous return. When veins fill the heart will go into its end diastolic volume. It's going to the end diastolic volume. So this is end diastolic volume. So what is preload? Filling, venous return or end diastolic volume. Now how is this preload related to stroke volume? More you fill the heart, more will come out. More the preload, more will be the stroke volume. Directly proportional to stroke volume. The other factor, afterload. Now this is loaded. After this load, I have the nostril. Now all this air is going to come out through the nostril. Aorta is like this nostril in the heart. If I increase the pressure in the aorta, blood cannot come out. If I release the pressure in the aorta, blood is able to come out. So what is present after the load? Aorta only is present after the load. So after load means aortic pressure. What is after load? Aorta, aortic pressure. But this one is inversely related to stroke volume because more you increase the pressure in the aorta, air cannot come out. More you release the pressure in the aorta, blood will be able to come out. So aortic pressure or afterload is inversely related to stroke volume, whereas preload and contractility are directly proportional to stroke volume. Afterload is inversely proportional to stroke volume. Excellent, Ranjan. Afterload, arterial vasodilators. Yes. How do we measure this cardiac output? By Fick's principle. What is Fick's principle? If there is any organ Arteries are bringing blood into the organ and veins are removing this. If you want to know how much of oxygen this organ has consumed, what will you do? You subtract arterial and venous. Arteries bringing in oxygen, veins are removing it. So if you want to know how much oxygen is consumed by this organ, you have to subtract this both. So arterial oxygen minus venous oxygen is oxygen consumption. Oxygen consumption is equal to arterial oxygen minus venous oxygen times the blood flow. You multiply this by the blood flow. When you keep blood flow on one side, take this to the other side. Now blood flow becomes oxygen consumption divided by arterial oxygen minus venous oxygen concentration. What is the blood flowing out of the heart? That is nothing but cardiac output. Blood flowing out of the heart is cardiac output. So if it is the heart, blood flow is nothing but cardiac output. So cardiac output or blood flow in the heart is equal to oxygen consumption divided by arterial oxygen minus venous oxygen. This is fixed principle. What are the other methods to measure cardiac output? Indicator dilution method, thermodilution method, Doppler, echo and MRI. All these methods can be used to measure cardiac output. Blood pressure and baroreceptor reflex. Very important, blood pressure. Baroreceptors. They are basically stretch receptors. Where are they located? On the aortic arch and carotid sinus. You have the baroreceptors. They are basically stretch receptors. Whenever blood pressure increases, it will stretch these receptors. So as a result, aortic arch receptors, when they stretch, they will trigger vagus nerve. And carotid sinus receptors, when they stretch, they will trigger glossopharyngeal nerve. So from aortic arch and carotid sinus, vagus and glossopharyngeal nerve arises. And this vagus and glossopharyngeal nerve, they will take the impulse into the brain. Now all this is taken into the brain, into the medulla, because medulla has center for controlling BP. Nucleus tractus solitarius is stimulated. So glossopharyngeal nerve and vagus nerve stimulate the nucleus tractus solitarius. Very good, Anirudh. It's for control of BP. Now what is the function of nucleus tractus solitarius? So this will activate the parasympathetic nucleus. Parasympathetic nucleus means the vagus nucleus. And this will inhibit the sympathetic nucleus. Sympathetic nucleus is VMC, vasomotor center. Parasympathetic is activated, sympathetic is inhibited. What will happen to BP if you inhibit sympathetic? BP decreases. This is called baroreceptor reflex. Increase in BP through baroreceptor reflex causes decrease in BP. Whenever you inhibit the sympathetic, along with BP, heart rate also will decrease. And this inverse relation between increase in BP through baroreceptor reflex causing decrease in heart rate is called Mary's law. What is Mary's law? Usually BP and heart rate will be on the same side. Either both will increase or both will decrease. But here, when they are connected by baroreceptors, increase in BP through baroreceptor reflex causes decrease in heart rate. Now it becomes an inverse relationship. This we call it as Mary's law. This is called the Mary's law. Yes. Try to answer these MCQs quickly. What is happening here? Radius is doubled. R becomes 2R. So now it becomes 2 to the power of 4. 2 to the power of 4 is 16. Excellent, all of you. So there is increase in 16 times. Flow increases by 16 times. Good. Vipul. We have a newcomer. Vipul. Good. This one. Can you try this one? This is a repeatedly asked question. Please try this one. What is answer? D, D. All of you are saying D 4 times. Any other answer? All of you are saying D. Okay, yes, Dheeraj is there. Is the correct answer. Only 1 minute, ma'am. Okay, I'll wait. We'll wait. Good. Now all of you are coming up with right answer. 8 times is the right answer. How did you get this? There's a smaller blood vessel with diameter D and length L. There's a bigger blood vessel with diameter 2D and length 2L. What will be the change in blood flow? So the question is about Poiseuille's law. So you write the Poiseuille's law. Flow is directly proportional to pi into delta P into R to the power of 4 divided by 8 times viscosity into length. So for the smaller blood vessel, this is the flow. For the bigger blood vessel, for this one, what is the flow? Flow is directly proportional to pi into delta P into D has become twice. Diameter has become twice. If diameter has become twice, it means radius also has become twice. The size has increased by 2 times. So radius also has increased by 2 times. So now it becomes 2r to the power of 4 divided by 8 times viscosity into length has doubled. So L has become 2L. So what is the difference between both? Pi same will cancel. Delta P is same. 8 and 8 is same. Viscosity is same. So what is the difference here? This 2 on numerator and this 2 in the denominator. So we have flow is equal directly proportional to 2 to the power of 4 in the numerator and a 2 in the denominator. All others are same. 2 to the power of 4 is 16. So we have flow directly proportional to 2 to the power of 4 is 16 divided by 2. 16 by 2 is 8 times. So we get 8 times change in the flow. Got it? Diameter is doubled means size is doubled. So radius also will be doubled. Only this 2 and 2 is different. 2 to the power of 4 is 16 in the numerator. We have a 2 in the denominator. 16 by 2 is 8. This one, can you try? Nobody? Go back to cardiac cycle. See, the question is, which of the following indicates end of isovolumetric relaxation? Is good, Ranjan? Dheeraj, Harya, good. Vipul is saying maybe D. Sahana is right. Pranchali is right. We'll do this. At the end of isovolumetric relaxation phase, what happens? We will go back to cardiac cycle diagram. This is isovolumetric relaxation phase. I'll just trace that now. Isovolumetric relaxation phase. At the end of isovolumetric relaxation phase, AV valve opens. What will happen if AV valve opens? Ventricle will get filled up. So ventricle is getting filled up. There is ventricular diastole. What is the first phase of ventricular filling? Rapid filling phase. During the rapid filling phase, what is the reason for rapid filling phase? Why it is rapidly filling? Atrial pressure is more, ventricular pressure is less. Because of the pressure gradient, it is rapidly filling. So what is the answer? Ventricular pressure falls below the atrial pressure. The gradient is more. That is why it is rapidly falling from atrium into the ventricles. So at the end of isovolumetric relaxation phase, ventricular pressure falls below the atrial pressure. Yes, D is the answer. This one, very simple. A wave in JVP, A for Atrial contraction. Very simple. A for atrial contraction. Yes. Which of the following does not increase the cardiac output? This one. When you do exercise, see what happens when you do exercise? Exercising muscle will pump on the veins. So venous return increases. When venous return increases, preload increases. When preload increases, cardiac output will increase. Yes. Increase in venous return, same, cardiac output increases. Increase in preload, cardiac output increases. Good, Ranjan. Afterload, because afterload is inversely proportional to stroke volume. More the afterload, less will be the stroke volume and cardiac output. So this is increase in afterload. This alone is inversely related. Which is the best index of preload? Which is the best index of preload? What is preload? Venous preload means venous return or filling or end diastolic volume. Now which one you will go? Aortic pressure is after load. Aortic pressure is not preload. Aortic pressure is after load. End diastolic volume. Left ventricular end diastolic volume. Preload means end diastolic volume. Afterload means aortic pressure. Got it? Okay. Calculate cardiac output. Can you calculate cardiac output? Any answer? A. Okay, Dheeraj says A. Others are saying Ayushi. So on, others are saying C. Some of you, because it's a max question, most of you are not trying. Try and give me an answer. C, C. Okay, we'll go with the C only. What is 50 ml here? End systolic volume. What is 120 ml? End diastolic volume. So what has been given in the curve? End systolic volume, end diastolic volume. What is 120 minus 50? Stroke volume. End diastolic volume, it was filled with 120. After the stroke, 50 ml is remaining. So how much has gone out? 120 minus 50 is 70 ml is the stroke volume. Heart rate already it is given as 70. Stroke volume is 70 ml. Now 70 into 70. This is 4900. This is a typical medico question. See, the heart rate is 70, stroke volume is 70. When you multiply, 7 sevens are 49. That is easy. 7 eights are 7 nines are will be difficult. So that's why 4900, 7 and 7 to make it easy for you. Yes, over to endocrinology. Endocrinology is a more of clinically correlated topic because mostly you'll see case history, diagnosis. So nothing much to understand, no concepts and all. So just you have to correlate with the clinical patients. That's all. First, we'll do growth hormone. We'll start off with the growth hormone. Growth hormone, what are the actions? See, the difficult part in endocrinology is remembering actions of the hormones. Growth hormone, thyroid hormone, cortisol, insulin, all of it will look like same actions only. What they are doing to carbohydrate, protein, highly confusing. So I will teach you one easy method to remember the functions of hormones, actions of hormones. For each hormone, we'll use one method. Now, first, growth hormone. We are going to learn only the actions. What are the actions of growth hormone? We'll divide it as in two stages of life. Before fusion of epiphysis, it means bones have not yet fused. It means in a children, in a child. After fusion of epiphysis. So how will you remember the growth hormone actions? It is all related to growth. What all you need to growth hormone will give you. So before fusion of epiphysis, in a child, growth hormone increases chondrocyte proliferation. If you increase chondrocyte proliferation, you can increase the height of the child. That is why excessive levels of growth hormone in a child results in gigantism. The height of the child will be more. So excessive levels of growth hormone in a child is called gigantism. After fusion of epiphyses, now the bones have already fused. Now you cannot increase the height because the bones have already fused. Rather than the height, it will start increasing others. Soft tissue increases, organs are increasing in size, hands and feet are increasing, eyebrow is increasing, jaws are increasing in size, jaws are protruding. So that is why excessive levels of growth hormone in an adult, all this will be seen. What is all this feature called as? Acromegaly. So acromegaly patients, you see, rather than the height, they'll have cardiomegaly, hepatomegaly, soft tissue will be bigger, hands and legs will be bigger, protrusion of jaw, prognathism, protrusion of eyebrows, all this together is called acromegaly. So excessive growth hormone in a child, gigantism, excessive growth hormone in adult is acromegaly. What are the other actions of growth hormone? It's all related to growth only. For growth, you need proteins. So, growth hormone increases protein synthesis. For growth, you need electrolyte. So, what growth hormone will do? It will take the electrolytes from kidney into the growing tissue. So it is removing the electrolyte from kidneys to the growing tissue. It is decreasing the excretion of electrolyte, taking all this to the growing tissue. For growth, you need energy. And energy comes from breaking down of fats. So growth hormone will use fats for energy. When fats are broken down, that is called lipolysis. When fats are broken down, they release ketone bodies. This is called ketogenesis or ketogenic effect of growth hormone. Ketogenesis. So that's why growth hormone is ketogenic. It is releasing ketone bodies. The other source of energy is carbohydrates, fats and also carbohydrates. But remember, carbohydrates will not be used by growth hormone. The raw material of carbohydrate is blood glucose. Blood glucose will not be utilized by the cells. It will use only fats. It will not use carbohydrate. If glucose is not used, over time, blood glucose increases, therefore resulting in hyperglycemia. So growth hormone is hyperglycemic. Growth hormone is ketogenic because it is breaking down fats, releasing ketone body. Growth hormone is hyperglycemic because it is not utilizing blood glucose, raising the blood glucose levels. So these are all the actions of growth hormones. So we have done the actions of growth hormone. Now, thyroid hormones. Thyroid hormone synthesis, steps in the synthesis are important. So quickly I'll tell you the steps in the synthesis of thyroid hormone. Then we'll go to the actions. We have the follicular cell and the colloid. Follicular cells will open into the colloid. So both follicular cell and colloid together they will help in thyroid hormone synthesis. Whenever we eat iodine containing food, this iodine is absorbed as iodide into the blood. And when this blood containing iodide flows across your neck, thyroid gland will capture this iodide. This transporter which will trap the iodide in the thyroid gland is called NIS, sodium iodide symporter. This will transport one iodide along with two sodium. This step is the first step. It is called trapping of iodide. And this step is blocked by two drugs, thiocyanate and perchlorate. Thiocyanate and perchlorate. So if you block this first step, you can use these drugs in the treatment of which disease? They are used in the treatment of? Yes, simply a follicular carcinoma is saying, okay, or simply hyperthyroidism. Hyperthyroidism. So what is hyperthyroidism? Yes, very good, Sonal. Excessive levels of thyroid hormone. You want to control the levels of thyroid hormone. You give thiocyanate and perchlorate. They will block this sodium iodide symporter. They will block the trapping of iodide. If you block the trapping of iodide, thyroid hormone synthesis will come down. So simply they are all anti-thyroid drugs. This NIS transporter is not only present in the thyroid gland. It is also present in gastric mucosa, choroid plexus, salivary glands, mammary glands, and placenta. But all this has no physiological role. When you do radioablation techniques, when you destroy the thyroid producing tissues in the blood for the treatment of hyperthyroidism, you should keep in mind that NIS is also present in these areas. Otherwise, they don't have any physiological role. So the first step is done. Iodide has been trapped by the follicular cell. This iodide crosses the follicular cell. On the other side, by the transporter called pendrin, it moves into the colloid. Pendrin is a iodide chloride anion exchanger. It will send iodide into the colloid. In exchange, chloride enters into the follicular cell. It is a iodide chloride anion exchanger. This pendrin, it is not only present in the thyroid gland, it is also present in the inner ear. So if there is any mutation of pendrin, that is called Pendred syndrome. So what will be the feature of Pendred syndrome? Hypothyroidism and deafness. So if you see a baby with hypothyroidism and also deafness, you should think of Pendred syndrome. It could be mutation of this pendrin. Now iodide has reached the colloid. In colloid, there are three steps: oxidation, organification, and coupling. What is oxidation? Iodide is oxidized to iodine with the help of enzyme thyroid peroxidase. That is oxidation. What is organification? Iodine combines with tyrosine to form monoiodotyrosine. Where is this tyrosine present? On thyroglobulin. So organification is one iodine combines with one tyrosine to form monoiodotyrosine. This is organification. This is also helped by thyroid peroxidase. Then we have coupling. They are going to couple with each other. Two MITs coupled to form DIT, diiodotyrosine. One MIT and one DIT coupled to form T3, triiodotyrosine. Two DITs coupled to form T4, tetraiodotyrosine. And coupling is also helped by thyroid peroxidase. There are drugs which will block this thyroid peroxidase. They are called propylthiouracil, methimazole, carbimazole. So for which disease can I use this drug? If these drugs block all the three steps, thyroid hormone synthesis will come down. So they are also used in the treatment of hyperthyroidism as anti-thyroid drugs by blocking the enzyme thyroid peroxidase. So now T3, T4 has been synthesized. It is taken into the follicular cell and stored in the follicular cell. Even for 2 to 3 months it can be stored. Whenever needed, it will be released into the circulation. Once released into the circulation, they are protein bound. 70% of T3, T4 binds to thyroid binding globulin or thyropexin. 20% binds to prealbumin or transthyretin. 5% binds to albumin. That was a repeat question. Which is the major thyroid binding protein? TBG or thyropexin? Yes, actions of thyroid hormones. So again, the difficult part, remembering the actions. So what we'll do, we are going to remember only one word, rates. Just one word. You remember rates. You can remember all the actions of thyroid hormone. Thyroid hormones will increase all the rates in the body. We will see head to toe what are all the rates increased by thyroid hormones. So we'll start with the brain. On brain, thyroid hormone increases the rate of brain growth. That is why hypothyroid cretin babies are mentally retarded. Because thyroid hormone increases the brain growth. Hypothyroid babies, there is no thyroid hormone, so they are mental retarded. Thyroid hormone increases the respiratory rate on lungs. On heart, thyroid hormone increases heart rate, increases systolic BP. That is why hyperthyroid patients are tachycardia. Hyperthyroid patients have tachycardia and hypothyroid patients have bradycardia. Thyroid hormones in the periphery, they can cause increase in rate of vasodilation. So what will happen if you cause vasodilation? Diastolic BP will decrease. Systolic BP increases, diastolic BP decreases. What is the difference between systolic and diastolic? Pulse pressure. So if systolic is increasing, diastolic is decreasing, pulse pressure also will widen. Increased pulse pressure. So thyroid hormones increase the rate of vasodilation, therefore decrease in diastolic BP and increase in pulse pressure. Thyroid hormones increase the rate of conversion of keratin into vitamin A. So what is the effect of this? Hypothyroid patients are not able to convert keratin to vitamin A. So keratin accumulates, giving carrot color to the skin. That is orange yellow discoloration to the skin. On bones, thyroid hormones, they increase the rate of bone growth. That is why hypothyroid babies are dwarf. Thyroid hormones on stretch reflex, they increase the rate of stretch reflex. For example, ankle jerk. Ankle jerk is an example for stretch reflex. Thyroid hormones increase the rate of stretch reflex. That is why hyperthyroid patients have exaggerated stretch reflex, whereas hypothyroid patients have slow, sluggish stretch reflex. Thyroid hormones on muscle. They increase the rate of proteolysis. Muscle proteins are broken down. That is why hyperthyroid patients have thyrotoxic myopathy. Muscle weakness because muscle proteins are broken down. On GIT, thyroid hormones increase the rate of gastric motility. If gastric motility increases, hyperthyroid patients will have diarrhea, hypothyroid patients will have constipation. On GIT, thyroid hormones increase the rate of glucose absorption into the blood. So quickly all glucose goes into the blood. Therefore, hyperthyroid patients are prone for hyperglycemia because quickly glucose is absorbed into the blood, their blood glucose level will rise. So hyperthyroidism is a diabetogenic state, hyperglycemia. On adipose tissue, thyroid hormones, they increase the rate of lipolysis. Fats are broken down. More the fats are broken down, hyperthyroid patients become thin and hypothyroid patients become obese. Overall, if you see, thyroid hormones, they increase the BMR. They increase the basal metabolic rate. Basal metabolic rate means all metabolisms are increasing. Metabolism means everything is broken down. When metabolism happens, there is more heat produced. That is why hyperthyroid patients become heat intolerant because their body itself is producing so much of heat. And hypothyroid patients become cold intolerant. Because of all the metabolisms, hyperthyroid patients, everything is broken down. So they have weight loss. And hypothyroid patients, metabolism is less. So they have weight gain. So all these are various rates increased by the thyroid hormone. You just remember the word rates. That's all. Let's just go through this. Adrenal gland. Adrenal gland, the layers and the hormones are important. Recently, there was an image question based on this. The adrenal gland has outer adrenal cortex, which is divided into zona glomerulosa fasciculata reticularis. The mnemonic is GFR, glomerulosa fasciculata reticularis, and medulla. Now, what are the hormones produced? Zona glomerulosa reticularis fasciculata, GFR. The hormones are salt, sweet, and sex. GFR for salt, sweet, and sex, which is the salt hormone aldosterone, which is a sweet hormone glucocorticoid. Gluco means sweet. So this is cortisol. What are the sex hormones? Androgens. So GFR produces salt, sweet, and sex. Aldosterone, cortisol, and androgens. What about adrenal medulla? Medulla produces catecholamine. What are the catecholamines? Epinephrine, norepinephrine, and dopamine. These are the hormones produced by the adrenal medulla. One important disease of the adrenal gland, Cushing syndrome. So we will learn the actions of cortisol now. How did we learn actions of growth hormone? All related to growth. How did we learn action of thyroid hormone? Rate. Now, Cushing syndrome. We are going to learn actions of cortisol. What is Cushing syndrome? When body is exposed to excessive levels of cortisol. The clinical picture is called Cushing syndrome. So, in a Cushing syndrome patient, all the features that you see are because of action of cortisol only. So, one action of cortisol has resulted in one of the clinical feature. So, we are going to learn the actions of cortisol by correlating with Cushing syndrome patient. So, Cushing syndrome patients have hair thinning, hirsutism, and acne. This is because whenever adrenal gland is stimulated to release cortisol, another hormone from the adrenal cortex is androgen. This also will be released. Excessive androgen in a female causes hirsutism, beard development in the female. So, excessive androgen exposure is responsible for this. Cushing syndrome patients have psychosis because the effect of cortisol is it can increase EEG, electroencephalogram. It increases electrical activity in the brain. That's why they go for psychosis. Cushing syndrome patients have cataracts. This is the effect of exogenous Cushing syndrome. When you take steroid therapy, excessive steroids from outside, that can cause posterior subcapsular cataract. Cushing syndrome patients have hypertension because whenever adrenal gland is stimulated to produce cortisol, another hormone from the adrenal gland, aldosterone, is also released. What is the function of aldosterone? Salt hormone, salt reabsorption. The more you reabsorb salt, blood pressure will rise. This salt retention will pull water, and water retention is responsible for edematous appearance of the face, moon face. Cushing syndrome patients have peptic ulcer because the action of cortisol is to increase gastric acid secretion. That's why ulcer. Cushing syndrome patients have loss of height, back pain, exuberant callus with fracture, osteoporosis, all bone related disorders because the action of cortisol is it will increase osteoclast activity. Osteoclast is bone destroying cell and it will decrease osteoblast. Osteoblast is bone forming cell. Bone destroying cell is increased, bone forming cell is decreased. That's why bone related disorders. Cushing syndrome patients have menstrual disturbance because cortisol will suppress ovulation, it will suppress FSH and LH. That is why they have menstrual disturbance. Cushing syndrome patients have tendency for infection, poor wound healing, and poor inflammatory response. Why inflammatory response is poor? Because all inflammatory mediators are decreased by cortisol. Inflammatory mediators like eosinophil, lymphocyte, phospholipase A, all these are inflammatory mediators. They are all suppressed by cortisol. Cushing syndrome patients have bruising because cortisol suppresses fibroblast proliferation. Only if fibroblasts are proliferating, you will have proper wound healing. If fibroblast is not proliferating, unhealed wounds on the skin, that is called bruising. Cushing syndrome patients have decreased skin thickness, wasting of proximal muscles, because the effect of cortisol is it increases proteolysis. Proteolysis means muscle proteins are broken down. Muscle proteins, especially in the hands and legs, are broken down to release amino acid. This amino acid enters into the liver, converted into glucose. This is called gluconeogenesis. New glucose is synthesized. Proteins are broken down, but glucose is synthesized. Some of the amino acid also enters into the liver to form plasma protein. So muscle proteins are broken down, plasma proteins are synthesized. When you have gluconeogenesis, this will result in hyperglycemia. That's why Cushing syndrome patients are diabetogenic. They are prone for hyperglycemia. Cushing syndrome patients have centripetal obesity and striae. This is because the action of cortisol is lipolysis. It will break down the fats, especially in the hands and legs. It will break down the fat. It will take all this fat and deposit in the abdomen. This is called centripetal obesity. Hands and legs will be thinner, but abdomen will be obese. Centripetal obesity. If you have more fat in your abdomen, it will stretch the skin, resulting in striae, purplish striae. So these are all the features of Cushing syndrome, but we have learned it along with functions of cortisol. So functions of cortisol, just remember Cushing syndrome patient. Yes. Insulin. What are the actions of insulin? How will we remember actions of insulin? Insulin is an anabolic hormone. Anabolic means building up hormone. It will increase all the storage forms. Just remember, insulin is anabolic. It is going to increase all the storage forms: carbohydrate, protein, and fats. We'll see what it does. When blood has glucose, insulin will send all the glucose into the cells and store it as glycogen. When blood has amino acid, insulin will push amino acid into the cells and change it and store it as proteins. Especially in the liver cells, glucose enters into the liver, stored as free fatty acid. So what is insulin doing? It is storing carbohydrate as glycogen, amino acid as protein, and fat as free fatty acids. That's why it is an anabolic hormone. It's a storage hormone. What is the relation between insulin and GLUT4?
ट्रेन से
Heart muscles, skeletal muscles.
हमेशा ये हुआ, मैंने बहुत नोटिस किया
Yeah,
जिस दिन मैंने ओपीडी देखी
okay. In heart muscles, skeletal muscles, and adipose tissue, there is a transporter called GLUT4. So what will insulin do? Whenever blood has glucose, so it will open up GLUT4 in cardiac muscle, skeletal muscle, and adipose tissue, and will send all the blood glucose into these cells. That is how insulin helps you to decrease blood glucose levels. So insulin, that's how insulin is decreasing blood glucose, by activating GLUT4. That's why GLUT4 is called as insulin dependent glucose transporter. Insulin dependent glucose transporter, that is GLUT4. What are the types of diabetes? Type 1 diabetes, it's called insulin dependent diabetes mellitus, because you have to treat it by giving only insulin, because the problem is their insulin synthesis is deficient, so you have to treat it only with insulin. Type 2 diabetes mellitus, here insulin is present, but there's something wrong with the receptor insensitivity. So you have to give drugs which will increase insulin sensitivity. Insulin is not of much use, but we give insulin to type 2 diabetes, but you will never see any patient taking only insulin. You have to give them drugs to increase insulin sensitivity. That's why it is called non-insulin dependent diabetes mellitus. Treatment is not dependent on insulin, rather drugs to increase insulin sensitivity. Yes, what is the other one? MODY, maturity onset diabetes of the young. What is the problem here in MODY? Defect in HNF, hepatocyte nuclear factor. So this is defective. If there is defect in this hepatocyte nuclear factor, this factor is important for insulin synthesis. So if there is defect in this factor, insulin synthesis will come down. So hepatocyte nuclear factor helps in insulin synthesis. If there is any defect of this factor, insulin synthesis comes down. This we call it as maturity onset diabetes of the young, MODY. Yes, over to the last part. Renal, we'll just do GFR, factors affecting GFR, and we'll finish with that. In renal, GFR is very, very important. What is glomerular filtration rate? The volume of fluid filter at all the glomeruli in both the kidneys per minute. The value is 125 ml per minute or 180 liters per day. In one day, your kidneys are able to filter 180 liters, or in 1 minute it is 125 ml. The urine output totally is 1 liter per day. This is the most important one. Listen. Starling's forces. GFR depends on Starling's forces. What are Starling's forces? There are two types of Starling's forces: hydrostatic pressure and oncotic pressures. What is hydrostatic pressure? Have you played like this? When you pour water in the garden, if you close half the nostril of the pipe, water will be pushed out with a great force. Or when water is pouring in a tap, you close half the nostril of the tap, water will be pushed out. So hydro means water. The water component of the blood will always giving you a pushing force. So wherever there is hydrostatic pressure, it is a pushing force. So wherever you see hydrostatic pressure, it will push the filtration to the other side. So hydrostatic force, pushing force, denoted by P. Oncotic pressure. Oncotic pressure is contributed by proteins, plasma proteins. You can imagine plasma proteins like a sponge. What will happen if you put sponge in water? This sponge will keep on absorbing water. It will keep on pulling the water. So if you put sponge in water, it is a pulling force. So like that, wherever you have proteins, they will exert a pulling force. So wherever there is oncotic pressure, it will pull the filtration to its side, denoted by pi. Don't forget, hydrostatic pressures are pushing forces. Oncotic pressures are pulling forces. So with that, let's apply this hydrostatic pressure and oncotic pressure on the glomerulus. So this is the glomerular filter. One side you have the glomerular capillaries. On the other side you have Bowman's capsule, which continues as the tubule. Bowman's capsule continues as the renal tubule. We'll apply these forces on the glomerular capillary side. GC means glomerular capillary side. So PGC is hydrostatic pressure on the glomerular capillary. Pi GC is oncotic pressure on the glomerular capillary. Pi T is oncotic pressure on the tubule, and PT is hydrostatic pressure on the tubule. Yes, now all of you are going to answer me this. There are two forces which will favor filtration and two forces which will oppose filtration. We'll find out. What are the two forces which favor filtration? PGC and pi T. Why PGC and pi T? PGC, hydrostatic force. This is pushing or pulling? Hydrostatic P is pushing or pulling? Pushing force. Good. So this will push the filtration into the tubule. If you push the filtration into the tubule, you are helping in filtration. So this will help in filtration. Pi T is oncotic. Yes, this is pushing or pulling? pi t, pushing or pulling? Pulling. But it is pulling from the glomerulus into the tubule. Again, it is helping you in the normal filtration. So the two favoring forces are PGC plus pi t. Opposing forces pi GC and PT. Pi GC, this is oncotic pulling. It is pulling from the tubule into the glomerulus. Now it is going in the reverse direction. Tubule into the glomerulus. So this is opposing. PT, hydrostatic in the tubule, pushing. But it will push from the tubule into the glomerulus. Again in the reverse direction. This is also opposing. So opposing forces are pi GC plus PT. So we know there are two favoring forces, two opposing forces. How will you calculate net filtration pressure? Net filtration pressure is simple. You take the favoring force and you subtract the opposing force. Favoring forces are PGC plus pi T and opposing forces are pi GC plus PT. So you just take the favoring forces and you subtract the opposing force. This is the formula for net filtration pressure. Normal net filtration pressure is around 10 millimeter of mercury. If you substitute the normal values, you get around 10 millimeter of mercury. So that is about the GFR and the forces here. This is also a very, very important topic, the favoring forces and opposing forces of Starling. So with that, we complete our discussion. Yes, I thought I'll do one thing. So all of you, just can you take your mobiles and I'll show you something. Clearance you want? Okay, okay. Okay, somebody is asking for clearance. Sure. We'll do clearance and then we'll go to that. So how will you measure clearance? So clearance is equal to U into V by P. This is the formula for clearance. If you give any substance, if you give any foreign dye into the patient, you know the plasma concentration, how much you have given. You measure how much has been cleared in urine. So much value P you had given to the plasma. Out of that, what fraction was cleared? U was cleared. So it is U by P and multiply this by the total urine flow rate of V. So clearance is equal to UV by P. When you measure the clearance, when you use any dye to measure this, if I use inulin to measure clearance, clearance of inulin is equal to 126 ml per minute. What is the normal GFR? How much is the normal GFR? Normal GFR is 125 ml per minute. GFR is 125 ml per minute. See, both are same. So whenever I measure the clearance of inulin, it is giving me GFR value. So clearance of inulin can be used to measure GFR. Now, creatinine. I'm going to measure creatinine. Sometimes there's a problem with inulin. Inulin is a foreign body. It is a foreign dye. It's a costly method. I have to purchase the dye and I have to inject it into the patient. When I give a foreign dye into the patient, some of them can go for anaphylactic shock reactions. So that is very dangerous. So in a small lab, we can't do inulin. Mostly the preferred technique is creatinine because creatinine is not a foreign body. It is already present inside your body. All your muscles are already producing creatinine. So when I measure the clearance of creatinine, it is giving me 140 ml per minute. What is the normal GFR? 125 ml per minute. When I measure the creatinine clearance, it is not exactly giving me the GFR. It is overestimating the GFR. So this is a less accurate method, but more preferred in clinical practice because you can avoid all these allergic reactions. So to summarize, the gold standard for measuring GFR is inulin only. But the more preferred technique in clinical practice is creatinine. If they ask you measurement of GFR, it is inulin only. Now, there's another substance called PAH, para amino hippuric acid. Whenever I measure the clearance of PAH, the value is 650 ml per minute. What is 650 ml per minute? Renal plasma flow is 650 ml per minute. So whenever I measure clearance of PAH, it is giving me renal plasma flow. So I'll summarize. For measuring GFR, you can use inulin and creatinine. For measuring renal plasma flow, you can use PAH. Clear? That is what about yes. Just a minute. Okay. So I think all of you are seeing this screen. Yes, all of you take your mobiles. Just take your mobile. You just click on the Google camera, so just the Google lens. Yes, can you just click on Google lens and scan this QR code that you will be seeing on the screen? Yes, just scan the QR code. All of you, please take the Google camera and scan this QR code. It will take you into a page like this. Yes, it's taking you into a page like this. Just give any name. Just give your name. Just give a short form of your name. And or you can even skip the registration. And you will see this question. So I'll show you a few questions. Just type the answer. Yeah, first question is, if not a doctor, what you would have become? Yes, that is our first question. You can see your answers on the screen. Are you seeing? Cricketer, lawyer, Namit. Is any other options? Teacher, nice. Robotic engineer, Tala. I like that. Father, oh my God. Who is that? Actor. Okay, the best answer is father only. We'll go for this best answer, father only. I think all of you are seeing the screen. Are you all seeing the screen? Like how I'm seeing? Yes, okay. We'll go to the next question. Insulin stimulates glucose uptake by. Can you type the answer? Insulin stimulates glucose uptake by cells through which of the transporter? Have all of you given an answer? Think an answer. Yes. Almost 67% of you have given facilitated diffusion. Excellent. GLUT4 is an example for facilitated diffusion. 21% of you have given secondary active transport. Why did you give secondary active transport? You have confused it with SGLT. That's why you're giving secondary active transport. Don't confuse. SGLT is sodium along with glucose, secondary active transport. But GLUT is only glucose. It is facilitated diffusion. See, the questions that I'm showing you now are all FMG repeat questions. Just for analysis, I'm showing. After the class, how much you're able to attend. Secondary active transport, those of you who gave, please correct that. Some of you have given primary active transport. Why do you give primary active transport? Primary is only ATPase. Only ATPase will be primary. Okay. The answer is facilitated diffusion. Yes. Answer this. Second one, please. Think and answer. This is your repeat question. FMG repeat question. Left shift. Yes. Decrease in temperature. Decrease in 2,3 BPG. And alkalosis. See, there's an oscillation. Still you're getting confused. Left shift. Left means something negative. So we'll place all decreasing factors. Decrease in temperature, decrease in 2,3 BPG, decrease in H plus. H plus is acid. If acid is decreasing, it means alkalosis. So the answer is first one. So 61% of you have given the right answer. The others who have confused, no confusion at all. Left shift means negative. Decrease in temperature, decrease in 2,3 ppg, decrease in H plus. H plus is decreasing means acid is decreasing. When acid is decreasing, alkalosis. Don't get confused. That's why I wanted this question. I think a year ago this was your own FMG question. Yeah, this one. Yes, just join the quiz. If it's asking your name, just type your name, nickname also. Tala, Namit, Saha, whatever. Just Ryan, whatever it is. Just give a name. Mafia. Hadi. Okay. Question. You have only 15 seconds to answer. Please answer. Only 15 seconds to answer. In restrictive lung disease, we forgot our discussion. Tiffany index, normal Tiffany index is 83%. In obstructive disease, Tiffany index falls to 50%. If Tiffany index increases to 90%, restrictive disease. So what is the answer here? Tiffany index is high in restrictive lung disease. FVC and FEV1 are not high. What is the normal FVC? 4 liter. In restrictive disease, it is only 2 liter. It is not high. What is the normal FEV1 of the 4 liter? It is 3.3 liter. But here it is not so much. So Tiffany index is high is the most correct answer. Okay, you can't say FEV1 is high because their FVC itself is only 2 liter. Out of that, 1.8 looks like it is more. But actually their FEV1 is not more. Yes, Tiffany index is high should be the correct answer. Okay, 90%. Yes, Tala is on top of the list. 15 seconds. Tala has given the answer. So you're on top of the list. Yes, maybe this is a small gift for Tala. You can just play with this. Next question. You have 15 seconds to answer quickly. Ryanodin. Superb. Most of you have given the right answer. What is malignant hyperthermia? Overactivity of ryanodin. More calcium is released. More muscle contraction. More heat produced. That is malignant hyperthermia. Ryanodin is the right answer. Again, congratulations. Tala is on top of the list, followed by DDDD, PAAG, Modi. Yes, well done. So we'll finish this quiz here. So that was just to give you an idea of assessment, how far you have listened well and revised well in the sessions. So we have come to the end of the session. So one thing what I wanted to tell you is the most important strategy for your exam is number one, revision, revision, revision. Don't study anything new in the last moment. Instead, revise whatever you have learned. Don't go in for any new groups or reading anything new. Just revise whatever you have learned. And the other thing is, if you spend 50% of your time for reading, please spend the remaining 50% of your time for solving MCQs. Because I have seen students who have just solved only questions and how to remember like you Dheeraj for 10 well, past 10 years I'm saying the same thing again and again. Dude, please don't compare with me and all, okay? Because one subject I'm doing it for 10 years, so that's not a big thing. What you are doing only is the most important thing, okay? So spend 50% of the time just for solving MCQs, because that is the more important part. Or I can tell you, even spend 70% of the time for solving questions. You can use any app, any Telegram group, any WhatsApp group, wherever you see questions, you get hold of the questions and get the answer for the questions. Because the more number of questions you come across, there is more probability that you will see this question in your exam. So I can tell you, solving MCQs is the most important part. Even if you're not able to read anything, sit and solve questions. Solve as many number of questions. Definitely you will be there in your exam. Yes. We've come to the end of the session. I will just now, I'll share the annotated PDF slides and the questions also. I have a short last minute revision notes. So that also I'll share it with the admin team. They'll share it with you. Any doubts if you have, you can ask. Yes, my best wishes to all of you. My sincere prayers. All of you should clear your exam. So next time you will not attend my class for FMG. Rather, you will come for NEET PG exams. So ready to join post graduation. So my best wishes and sincere prayers to all of you. Thank you so much. Telegram. Yeah, I'm there in the Telegram. Dr. Abirami Vaithalingam. I'll just type in my number to all of you. Just take my number. 85037. I've just typed in my number. You can just take it. Oh, I think it has gone only to Dheeraj. Okay, to all. Okay, I'm just typing my number. You can save my number. You come across any difficult question, you post it there. 844850337. Yes, I'm there in WhatsApp, Telegram also. So any difficult question you come across, please be free to share it with me. Yes, thank you so much for joining in this session. Very small group, but still interactive students. All the best to all of you. Thank you. Yeah, any doubts if you have, you can post. Or anything you want to say, you can post. Thank you, Dheeraj, Ranjan, Hadia, Sahana Bhaskaran, Suanil, Pranchali. I think Anirudh was also there. Hadia, this session was so helpful. Thank you. Thank you, doctor. You made physio so easy. Thank you. Thank you. Thank you so much. Any other queries you have, you can just post it. True. Dheeraj says something is true. Thank you, Saif Ali. Made physio easy is okay. Okay. Yes, in between, I saw Dheeraj. He just came out of the camera, and all of us saw you. Yes, anytime you can post questions in the Telegram. Please do.